Welcome to Med Practice Made Perfect, brought to you by Practice First Medical Management Solutions. My name's Tom Mahar, and I'll be your host. Today we have two special guests. We have our coding managers, Kelly Cole and Vidya Baliga, who have been with us for, 2014, I think it's been. So it's been about 9 years. They are both certified coders and certified auditors through AAPC. And welcome, guys.
Hi, Tom.
Hey, Tom.
Thanks for having us.
Thanks for having us.
Yeah, we appreciate you guys joining us today. I'll give you a little bit of a brief history as to what's kind of transpired over the last 20, 25 years, whatever it's been since we've gone to an electronic health record. Maybe it's not quite that long, but generally speaking, the last time before 2021 that the evaluation and management guidelines were updated was 1997. So there was the 1995 and the 1997 evaluation and management guidelines. So generally, and this is a little bit of a generalization, but the 95 guidelines were basically used by non-specialists, and the 1997 guidelines were typically used by specialists. That's typically the way that it worked out to be the most fair code, if you will. So now we went, whatever it's been, 23 years since an update, and there's really been a lot of changes. So the way things were designed before is there were the codes were devised based upon the three sections of history, the section of exam, and then the section on medical decision making. So, what's basically happened over time is when the electronic medical records came out initially, what they did was they created a bunch of check boxes. So within the history and the three sections of history and the exam, the clinicians were performing their exam on the patient, checking a bunch of boxes. Same thing within the MDM section. And, they were creating a recommended code, if you will, as to what this should code out as. So that, generally was a guide. It was an aid, to a coder. There was, all kinds of issues within, conflicting information that you could get within a history section, or where the same thing was used within two different sections of history. So you'd be double counting elements and that sort of a thing. As time has, gone on, the general idea was the government was incentivizing practices and paying practices, to implement electronic health records. So that happened maybe, I don't know, maybe it was 4 or 5, 6 years ago. Maybe it's been longer, to try to get everybody on electronic health records. So, the theory was, the government thought that the theory was, well, if everybody's health record is electronic, it'll be easy to share and so forth. Unfortunately, it didn't work out that well, in that there were hundreds of electronic health record systems, and none of them spoke to each other for the most part. So that was a little bit problematic, but the good part was that all these paper records, a lot of them went away, and we ended up with at least an electronic record. The funny thing that happened, though, with all this box checking and so forth, and what ended up happening is there's always been a bell curve on your E&M distribution, from the lowest level 1, to a highest level 5. And within that, that bell chart, a lot of the stuff fell towards the middle. So one of the phenomena that happened, when everyone started using electronic health records, is all of a sudden the acuity, the whole bell curve shifted to the right towards, higher acuity. So, so the government got annoyed. Obviously, they've already paid everyone to, implement the electronic health records, and now they're paying more money out because all of a sudden, just from a simple documentation and coding tool, it's generating higher level codes. So, the government kind of stepped in and then looked at government payers and started looking at, along with regular commercial payers, started looking at, the actual leveling of these charts. And there was, quite a few more audits that occurred and so forth to discourage this, quote unquote, overcoding. So that's kind of the backstory. And then, what's happened, since is January 1st, 21, for a good portion of medical providers, the 2021 Evaluation and Management Coding Guidelines came out. And really for the rest of the providers that came through, I think it was, correct me if I'm wrong, guys, it started January 1st, 22, and then the rest of them that rolled out January 1st, 23?
No, the first one was 2021 and the next one was 2023.
Okay, great. So what's transpired here, or the big change, I should probably say it, is that the history and the exam no longer became relevant as far as, a use for coding. They really wanted the provider to focus on documenting, number one, the medical necessity of the visit, and then number two, they wanted them to, what are they thinking about in the medical decision-making section? What did they consider to make their final, analysis and diagnosis of the encounter? So concerning the 2021 guidelines, it's basically where, we're focused on the medical decision-making. So within the medical decision-making now is the major part of the chart, and really what we're considering along with medical necessity, and medical decision-making, medical necessity, we're considering to score the encounter from a level of service situation. The history and exam, they're still being reviewed by coders. They're sometimes looking for conflicting statements in there, that sort of a thing. But it's not used, I believe, in consideration of what the final code is that we're looking at.
Correct.
So, okay, so so generally, Vijay and Kelly, if you guys can speak to, a little bit about, the E&M scoring tools in general, and how this works within an EHR.
Sure, I can start. According to the E&M guidelines, there are 4 different types of medical decision making. So you have straightforward, low, moderate, and finally the high level. And medical decision making, or what we'll refer to as MDM, is defined by 3 elements and organized into what is referred to as the MDM table. So an EHR scoring algorithm would be based on the 3 different columns or 3 different elements, let's say, in the MDM table. So without going into the specifics of how to code or the requirements for each of the columns of the MDM table, I would note that the 3 columns are the number and complexity of problems addressed, so the issues the patient walks in the door with, the amount and or complexity of data to be reviewed and analyzed. That would be the ordering of tests, if the provider spoke to another provider outside of their practice. Also, if an independent historian, maybe in the case of a child or something along those lines, was used to gather history information. There are all data points that can be given for these things. And any diagnostics ordered also would count there. And then the 3rd column would be the risks of complications and or morbidity or mortality of patient management. So any EHR E&M scoring algorithm would need to look at all 3 of these columns, take them into consideration in order to calculate an overall E&M level.
Okay, so that was a great summary, Kelly. In your folks' experience with EHRs, how does the algorithm work?
I can take this one. Typically, for the algorithm to work, there would be boxes to check. So a provider or a user would have to check on the appropriate boxes for the EHR to generate an E&M code. So let's just walk through an example. A child comes in with a sore throat and is diagnosed with pharyngitis. So now the provider would click on a box that says it's an acute, uncomplicated illness in the first column. Then moving on, the provider probably ordered a strep throat and also used, like the parent provided history in addition to the child providing the history. So the provider would have to click in the data column, they would have to give credit for the test ordered and also give credit for the independent historian. And then finally, in the risk column, the provider would have to assign a risk to the condition. So in all, the algorithm would basically consider all three columns to come up with an E&M final code.
That's that sounds fairly complicated. I can see based upon your example of just certain things happening. If you go, if a parent goes in with a child, they may, the provider may have, may write down, history obtained from, from parent, from mother or whatever. And, then they forget to check the box.
Absolutely.
If that's what it was.
Absolutely.
If you forget to check the box, that of course is the problem where you're not getting credit for that element. Okay. All right. That makes a lot of sense. So I guess the next question that comes up is that, I think a lot of the ways that, the software companies are selling these packages is, the kind of the same way they sold medical billing packages, and they, look at, if you implement this package, it's going to do everything for you. It's the same kind of thing on the health record, the electronic health record. If we've got algorithms built, it's going to select the code, and the issue is, as you guys, pointed out, is, the problem is these check boxes. So maybe we could talk a little bit more about, why do we still need a coder? I mean, if these algorithms are figuring things out, we talked about a couple, pitfalls, but, why do we need a coder anymore?
I would say, first of all, there are several reasons, but it's important to remember that even with the new E&M guidelines, one thing remained the same. The medical necessity of the visit still remains the overarching criteria for leveling a service. And I would say that algorithms cannot determine if the visit or the service was medically necessary. One example would be, we've seen visits where the chief complaint maybe is ear pain. And along with the management of the ear pain, we may see a random order for a urinalysis documented with no other information in the chart as to the reasoning behind the why of ordering the urinalysis. So in this case, the medical necessity of the urinalysis is missing. And a coder would be able to see that and would query the provider to question the reasoning behind the urinalysis. And it could be that the urinalysis, like order box, was clicked on, but a urinalysis maybe really wasn't ordered. Or was done unintentionally. Or it could be that there's an underlying reason why the provider felt a urinalysis was necessary, but he or she missed that in their documentation. So having a coder's eyes on this, being able to see that, the coder, it allows the coder to query the provider. So either, that order can be taken out or supporting documentation added in to ensure that the medical necessity is there and that the chart would withstand an audit.
Also, like the algorithm basically relies on the provider to check on the appropriate box. So we've seen so many examples where the provider will click on a high risk of morbidity for something as simple as a conjunctivitis. That doesn't mean that just because they click that box, that's a high risk patient. On the other hand, we've also seen where the patient comes in with chest pain, has an abnormal EKG, but the box checked is uncomplicated illness. So in both cases, just checking a box doesn't basically outline the true risk. Like the documentation has to speak to the risk of the patient, of what they're managing.
And I think in those examples that you gave, Vijay, the first example, that would be a case where like an acute uncomplicated illness could end up going out the door, without a coder's eyes on that chart, could end up going out the door
as a level,
as a higher level, and not then be able to withstand an audit for that level. And at the same token, that the case with the chest pain and an abnormal EKG, it's going to go out the door at a lower level when it could have been a higher level and reimbursed at a better rate.
Okay, so it sounds, in summary, for to that question, it sounds like if the provider is not completely accurate with their box checking, the algorithm might be, if it's written, it might be perfectly fine. The problem is if the boxes are not checked properly, you really run a risk that it's going to be the wrong code. And what do you want your doctors and APPs doing? I mean, making sure that they check the right boxes and they can guess that the right code was generated, or would you prefer to have someone that's a professional in this area looking at that? So that's very interesting.
In terms of why a coder would still be necessary, in most cases, and this is one of the biggest things, is that in most cases an EHR, E&M algorithm calculator cannot read free text. And we see often that additional revenue generating codes are noted in the free text MDM sections of a chart. So a provider may note additional procedures within the free text as opposed to a separate maybe procedure section. And a coder will read that and pick up on these additional codes that could be added and prevent lost revenue opportunities.
And then another example is sometimes we've seen the providers add risk statements within the free text MDM, and something where you would see that the exam is normal, and in the free text MDM, the provider would add that the patient is stable and can be discharged home, and then goes on and checks the box of high risk. So there, the free text is telling us that the patient is stable enough to be discharged home, and this truly isn't a higher acuity case. It would either lead the coder to query the provider on it, or code it at an appropriate level. Without a coder's eyes, it would have gone out as a higher level. And the case can also be reversed, where there's a higher risk statement, but the box checked happens to be a low risk. So that's something that we come across very often.
And I think too, because an E&M calculator or the algorithm doesn't consider the free text, there is a risk of incorrect documentation leading to what could be compliance issues. So sometimes templates are not updated or tailored to the particular patient in that particular encounter, and a coder's eyes are going to see that. It could also be that there's conflicting information in the note. And again, that would be questioned on audit. So a coder has the opportunity to query the provider to say, it could be conflicting laterality, or it could be that, the one section says the patient has a cough, the next section, the patient denies the cough. Right. So things like that, a coder is going to pick up on and be able to query the provider, and the provider would have the opportunity then to amend the note to make sure that it would withstand an audit.
Okay. All right, that's great. I guess the next question that comes up is, what other ways does a practice benefit from using a coder? I mean, what other reasons, would a practice, require a coder?
So one of the biggest reasons for the E&M guideline changes was they wanted to move away from box checking, note bloating, because a lot of templates were built such that the providers would click boxes, the note would look like in terms of pages, it would be 15, 16 pages with information that wasn't always necessary for that particular visit. Now, again, if we go back to box checking, I think we're missing the entire purpose of that guideline change, which was to make the MDM more clinically intuitive and for the providers to document that their thought process and focus on patient care, which is which is what they're supposed to be doing. So when you hire a coder, the coders are trained to read through the chart, extract the information, use the guidelines, and apply it to come up with the most appropriate level of E&M for that visit.
I would think too, a definite benefit, especially over the past 3 years, to having a coder is that the guidelines currently, during the PHE, there were constant updates and guideline changes. At the same time, there was a huge spike in clinic volumes. So it became necessary for the providers. They needed to really focus on the patient care and not worry about keeping up with the guidelines, the current changes, when, there were modifiers that suddenly needed to be added, things like that. All of that was really important for the coders to stay up on and ensure for the practices that the charts went out the door coded correctly to avoid, things being sent back by the carriers and things having to be looked at a second time. So it's the job of a certified coder to stay up to date on all of those guidelines and changes.
Also, I think we're seeing across the nation the shortage of providers. So do we really need a provider to be doing the job of the coder and taking away time from patient care?
Yeah.
So,
and I think one of the things that we also, I know that we've talked to our clients about, that the patient charts are medical legal documents. And the coder can identify any documentation risks and provide appropriate feedback to the providers. So we've come across examples where information from one patient is in another patient's chart. I know we had one where an x-ray for somebody, for instance, it could be in the wrong patient's chart. And the coder's going to notice this and be able to, alert the providers and clinical staff and so that they can get that issue corrected. And without a coder looking at that note, that could very possibly go unnoticed.
Yeah. And then the ICD-10 and the CPT undergo changes each year. I think the number of codes in the ICD-10 data set is over 73,000. Right. And then CPT must have at least more than 10,000 codes. So to expect a provider to keep up with these changes and choose the most appropriate code, I think is asking too much of them.
Right. Well, those are all very salient points, ladies. In conclusion, I think, I guess a couple thoughts come to mind. Assuming that the EHR algorithm is correct, the basic premise is that, to derive the right code, you've got to rely on the provider checking all the right boxes. And not only checking the right boxes, but then also making sure that their free-form text with, their thoughts and considerations, et cetera, support what those boxes checked say. And trying to expect a doctor and APP to consistently do that and get their final decisions documented with the right boxes checked, that's a little bit of a reach. I think the other point that you guys had made is that, many times that there's conflicts within the note. Algorithms are not going to pick up, those conflicts. And, if you're audited, you've got a potential compliance problem. From a lost revenue standpoint, I think the other thing that you guys mentioned was that, many times there's procedures that are mentioned in that free form text. If they forgot to check the box, it's not going to get coded, and therefore it's not going to get billed, and it's a lost revenue opportunity for service that was actually performed. So, and as Vijay, I think just relayed, in today's day and age of, shortage of doctors and mid-levels, do we really want them toiling over charts rather than having, straight patient time where, they're treating the patient and then clearly documenting, what they did and what they're, and what they're recommending. That's it's that the shortage is not projected to improve, anytime soon. So, I guess the summary of this whole thing basically is, the minor cost that it is to pay to have your charts coded, either by an in-house coder or a service that's out of the house. It minimizes the compliance risk and ensures that you're capturing all your revenue. So, really great session today, Kelly and Vidya. Appreciate your time here today. I hope it was useful information. As everyone knows, we talked about before, I can be reached at tom@pracfirst.com or at cell phone number 716-861-1199. If anyone has questions out there, please feel free to get them to me, and I will certainly get them to the experts, Kelly and Vidya, to help us answer.
Happy to help.
So thanks for your time, everyone. Thanks, guys.
Thank you for having us, Tom.
Thanks for listening to Med Practice Made Perfect.